Welcome to the use of PHQ-2, PHQ-9 Patient Health Questionnaires for Depression Screening in Primary Care conference call. My name is Rebecca, and I will be your operator for today's call. At this time, all participants are in a listen-only mode. Later, we will conduct a question-and-answer session. I will now turn the call over to Joe Kalidas. Joe Kalidas, you may begin.
Thank you. Good morning or early afternoon to everyone, and welcome to today's Learning in Action Network event from the Lake Superior Quality Innovation Network. My name is Joe Kalidas, and I will be the moderator for today's event. We're very pleased to have Chris Beamish and Linda Damon from Fairview Health Services in the Twin Cities of Minnesota with us to describe Fairview's innovative process for depression screening and follow-up. A few notes as we get started. Today's webinar will be recorded and the presentation slides can be downloaded. The link to download is in the chat window that you see in the WebEx session. The recording is usually available in a week or so, and we will email participants with a link to the website to get to that. As noted, phone lines are muted and we will be engaging later. In the meantime, we encourage you to use the chat feature of WebEx as questions come to you during the presentation, and then we'll address them along with phone questions and Q&A. And finally, if your organization isn't participating in our project, contact information is at the end of the presentation for you to follow up if you are interested in learning more. The Lake Superior Quality Innovation Network is a joint venture of MPRO in Michigan, Metastar in Wisconsin, and Stratus Health in Minnesota. Our work is part of the latest generation of CMS Quality Improvement Organization initiatives, and today's webinar is part of our work in mental and behavioral health. Our project includes work both in ambulatory and inpatient care. On the ambulatory side, our goal our goal is to increase screening for depression and alcohol use disorder in primary care clinics and physician practices. On the inpatient side, for patients discharged with a mental health diagnosis, we have goals in two areas. First, to increase follow-up with a behavioral health professional at 7 days and 30 days post-discharge, and secondly, to reduce the 30-day readmission rate for patients that are discharged. Today's webinar will focus on the ambulatory goal for depression screening. Introduce today's, first of all, talking a little bit more about what we'll see. Today we'll learn how Fairview Health Services uses the PHQ-2 and PHQ-9 depression screening tools as part of their very comprehensive and integrated process. To introduce today's presenters, Chris Beamish is manager of Fairview Counseling Centers and Clinical Systems Integration, part of the mHealth academic health system through the University of Minnesota here in the Twin Cities. He is responsible for the clinical, operational, and financial performance of a team of outpatient clinic therapists and integrated primary care behavioral health clinicians. Chris is also lead motivational interviewing trainer for Fairview and mHealth and is a member of the Motivational Interviewing Network of Trainers. Linda Damon is Senior Epic Engineer at Fairview Health Services. Linda is an experienced project specialist and systems analyst supporting patient care, ancillary processes, and associated applications. As I turn it over to Chris, we will pause briefly here and look forward to Pat.
Hello, everyone. My name is Chris Beamish, as Joe said. I'm glad to be presenting to you today on our use of the PHQ-2 and PHQ-9, specifically via our My Chart functionality, an electronic means of administering the PHQ-9 to patients for depression screening in primary care. Fairview Health Services is a nonprofit healthcare system that's based in Minneapolis. We deliver care to patients at all stages of life and are really committed to high-value, superior outcomes and exceptional patient experience at a lower cost of care. Our primary care network is made up of more than 500 primary care providers across 44 Fairview Medical Group primary care clinics. We also have a larger Fairview Health network, which is made up of our affiliates. Within our 44 primary care clinics, we have 8 integrated primary care behavioral health clinics. And I'll talk in just a little bit about the use of a behavioral health clinician as a key member of that team to support our PHQ-9 follow-up. In 2015, the AHRQ recognized Fairview Health Services integrated behavioral health clinics as one of 8 exemplar models across the nation. Fairview Counseling Centers is a specialty mental health department with co-located therapists doing traditional individual, couples, and family therapy. And those FCC, Fairview Counseling Center specialty therapists, are co-located in 24 out of the 44 primary care clinics. Fairview Health Services is the largest behavioral health provider in the 5-state area. And we'll be talking about our partnership and the collaboration that we have across our behavioral services and primary care services today to achieve depression screening via the MyChart screening tool. Many of you on the call are probably well-versed in the use of the PHQ-2 and PHQ-9 for depression screening and know that those tools include diagnostic criteria from the DSM-5 that are patient-reported and indicate the severity and the frequency of their symptoms. So here's a screenshot of what our MyChart PHQ-2 looks like for a patient. They receive this electronically, they're completing this over the computer, and it's attached to an annual exam or physical. So it automatically goes out to patients when they have a physical or annual exam coming up, and it's scheduled. So these first 2 questions, if responded positively, that is a score greater than or equal to 3, results in automatic administration of the PHQ-9. So the patient is then prompted to complete the remaining 7 questions. A score of greater than or equal to 10 and a diagnosis of depression will result in indexing by the Minnesota Community Measurement for our health system. And this is one of our very important quality improvement measures that we are addressing as a system. So I'm going to pass the ball over to my colleague Linda Damon as we talk more now about the screening tool.
Hello, everyone. This is Linda. Let's see. I am now presenting. So last year in 2015, Fairview began the implementation of MyChart questionnaires when patients were scheduling. Let's see. I want to get to the next slide here. When patients were scheduling an annual exam. Previously to that, all PHQ-9s were performed in the office or over the phone with clinical staff involved. So moving to MyChart questionnaires took the clinical staff out of the picture in many instances, so we needed to come up with a way to ensure that electronic responses were reviewed in a timely manner. So PHQ-2 and PHQ-9 are parts of our standard rooming process for most visits, previously completed with clinical staff entering the results. With the new process, it was took the staff out of the picture in many instances, and so we set up several different stopgaps. For one thing, the primary care physician, if the patient responds positively to the PHQ number 9. For suicidal ideation, if they respond positively to that in MyChart, the physician will receive an in-basket alert. So another part of this project was to consolidate the many different ways we had of entering results into the electronic medical record that had been developed over the years. We also had health maintenance and best practice alerts to consider as we did this consolidation. Those different methods will automatically update the health maintenance and the best practice, so any changes that we did make to that process or that data entry had to address updating these two processes also. And we also wanted to ensure that appropriate follow-up was performed at the right time. One of the questions with this best practice alert was, what if the patient does not have a valid primary care provider attached to their record? So we kicked off the process with, I'm going to hand this over to Chris right now. He's going to take you through the process.
Although you'd be well-versed enough to go right through it, I'll pick it up with you. So our VP of Quality and Innovation for Fairview Medical Group pulled together a work group to lead the MyChart PHQ-9 initiative. That team did some research on best practices regarding PHQ-9 screening and follow-up. We looked at the two ways that we saw to administer the PHQ-2 and PHQ-9 via MyChart, and those two ways were via an EMR automatically attaching or assigning the PHQ-2, PHQ-9 to the annual exam for a patient. So this automatically goes out to patients who are enrolled in MyChart, and there's no manual touch required by our staff to make that occur. If the patient completes that PHQ-2, PHQ-9 via MyChart and comes in for that appointment, they are then met by the primary care provider who would follow up on those responses during the clinic visit. For the instances where we would manually assign a PHQ-2 or PHQ-9, we might send that out for a medication refill, or when a patient is due for PHQ-9 follow-up at the 6-month interval for Minnesota Community Measurement Standard. When they're manually assigned to a patient, the information comes directly back to the person who assigned that PHQ-2, PHQ-9. So if the primary care provider received a medication refill request from the patient and they wanted to know how the patient was doing, they could send out the MyChart PHQ-2, PHQ-9 and receive that response back. If there was a score that was concerning for the provider, they could request that the patient come in for a visit in order to get that refill. Or there could be more immediate proactive outreach provided to that patient by the care team. We, as a part of this team, also explored, as we were considering our mechanisms for distributing the MyChart PHQ-2, PHQ-9, we explored what resources we have within our system. As I mentioned before, there's a great partnership between our Behavioral Services Department and our Primary Care Services. And we looked at what are the current processes that we have in place and teams that we have in place to support this work. And we learned that as the MyChart PHQ-9s were being sent out, shortly thereafter, after this was implemented, we learned that the phone number we were providing was going to our after-hours triage, our nurse triage line. And the nurse triage line would then identify the patient's needs and forward them on to our behavioral central intake number, who would do further screening and assessment. And so as we wanted to standardize this work, we wanted to take out the middle person and get the patient connected to the right resource at the right time. And we also realized that as we did this as a system, that there was going to be a greater volume of patients needing the support. So we looked at what's our current capacity of that behavioral intake team to do assessments of patients who have a positive response to question number 9 on the PHQ. So our VP of Quality and Innovation created an SBAR. Through our work, we put together an SBAR for our senior leaders related to the proposed workflow and a disclaimer for patients related to MyChart PHQ-9. And a big reason for wanting to put a disclaimer on the PHQ-9 was so that patients had guidance on what to do if, in the event they began to feel unsafe while completing that PHQ2, PHQ9 electronically in their home. We met with risk management, had several conversations with leadership across the system in coming up with what that standard disclaimer would look like. And then we also met with Pfizer to get permission to put that at the beginning, at the top of our PHQ2, PHQ9 via MyChart. Here's an example of what that would look like for a patient. So when they are sent out the PHQ9 via MyChart, it states the following. This is a questionnaire about depression for your upcoming visitor contact, and your care team may not see this information before then. We care about you. If at any time you feel unsafe or have concerns about your safety or the safety of others, please take immediate action by calling this National Suicide Prevention Hotline. For mental health crisis support, 24 hours a day, 365 days per year. As always, you can also go to your local ER or call 911 if you have immediate safety concerns. So as we were looking at our internal and external resources, knowing that these MyChart PHQ9s could be completed at any time of the day, so we're automatically sending them out to patients when they have an annual exam due. And just because we send it out during business hours doesn't mean they're going to complete it during business hours. We knew that we needed to have a fully responsive 24/7 service to support any needs that came up for that patient. So we connected with the National Suicide Prevention Hotline to ask them about their capacity and willingness to take on the volume of calls that could come from this. And they said, we want to connect you with your local level support, which is the Crisis Connection Program. And we talked to Crisis Connection and got approval to have this number listed as the first line of service for patients in this disclaimer. Also, just knowing that patients could go to the local ER or call 911 if they had immediate needs, and that would be recommended. Okay, so back to Linda here.
Okay, so now I'm going to get into a little bit of the build and the workflow and show you what somewhat of what the patient sees and then how the alerts work for our providers. So in addition to adding the disclaimer to the beginning of the PHQ-9, we also developed some follow-up questions if the patient answered positively to number 9 regarding suicidal ideation. So if they answered positively to number 9, they then received this first follow-up question that has some instructions on it, and I have those highlighted here, indicating that they felt as though they would be better off dead or have had thoughts of self-harm, and then we just wanted a few more questions.
I would add, too, to that, that the reason we really wanted to tease that out was that the PHQ9 question number 9 is a double-barreled question. It's stating that the patient is either feeling like they'd be better off dead or they're having actual suicide ideation at this time. And so we wanted to better understand what it was that they were experiencing so that we could provide them with, provide our team with better information for follow-up.
So this is the logic behind those 4 follow-up questions. The first one is, in the past 2 weeks, have you had thoughts of suicide or self-harm? So then there's 2 pathways. If they answer yes, they get the next 2 questions, questions 2 and 3. If they answer no, they just get question 4. So if they answer yes, it asks, the second question asks about a plan or intention, and the third question asks if they've acted on that plan or that intention. And then the fourth question is asking about concerns for their personal safety of themselves or others. Did you want to add anything to that, Chris?
Nope, that's great.
Okay. So that brings us to the best practice alert. If they answer positively to number 9, they fill out those follow-up questions, and then our EMR, which is EPIC, kicks off a best practice alert to the primary care providers in basket. So this is flagged as a high in basket alert, and the message, once they open that message, it will display information that's pertinent to that patient, including their demographics, which also includes their current employment, their current and past PHQ-9 responses. It includes recent outpatient visits, their preferred pharmacy, current medications, problem list, and their patient care team. So this is an example of what the provider would see in their in-basket. I have this top person highlighted here. So it gives you the patient's name and the date of the visit. And then if they had more than one PHQ-9 filled out, you would be able to see the trend here. This is a flow sheet. When they answer positively to number 9, I should have my laser here, sorry. When they answer positively to question number 9, these are the follow-up questions that were presented to them in my chart, and they can see those also. They can then scroll down and see the rest of that report and the other pertinent information. So the next question for us was, what if a patient responds positively, has suicidal ideation, and does not show up for their appointment? Nobody would be reviewing those responses because they're usually reviewed during that scheduled appointment. And another point to pull out was, what if the patient's primary care provider was no longer valid or had like an unknown doctor and there was blank? And so nobody's getting that best practice alert. So what we did is we created a report that looks at the scheduled patients, and if they had a PHQ-9 completed and kicked off that best practice alert for suicidal ideation and either did not show for that appointment or canceled their appointment, that patient would be added to a report, which is then emailed to the behavioral health clinicians to follow up on. So this is a high-level workflow of our rooming, of how the patient fills out the questionnaire and what happens when they're roomed or if they do not show for their appointment. So the patient completes their PHQ-9. If there are thoughts of self-harm, the primary care provider receives a best practice alert. If they do not have that, if they do not say they have thoughts of self-harm, there is no further action taken. Then the next question is if they attend their scheduled appointment. If they don't, they get onto the report that the behavioral health clinicians follow up on. If they do show up for their appointment, they're roomed by the staff, and then the provider then is responsible for following up on those PHQ-9 responses. And this is the workflow that we have worked out for them. Review the PHQ-9 responses. They assess the patient for safety, decide if their transportation hold needs to be performed. If no, then they do a safety contract, a verbal safety contract with the patient, and refer to the mental health. If they do not show up for their appointment, they get onto the report for behavioral health, and I'm going to let Chris speak to that.
Just pulling up my laser pointer here as well if I can get it to work.
Okay.
There we go. Okay. So if the patient doesn't show up for their appointment, we have behavioral health clinicians. We have currently nine behavioral health clinicians in those integrated primary care clinics that I mentioned before. Behavioral health clinicians are licensed mental health professionals that are credentialed providers able to bill for services. They do diagnostic evaluations and provide brief evidence-based practices to patients at the primary care level. So this team of BHCs had a email distribution list created, and when a patient showed up on that daily report, that report would be emailed to this distribution list of BHCs. We identified a BHC champion who was ultimately responsible at the end of the day to make sure that some action had occurred for patients to show up on that list. The team, because they are providers, they're working in a busy primary care clinics, are doing this work amongst their other responsibilities, which includes providing patient care and some population health outreach. So we wanted all BHCs to be looking at that report, knowing that we didn't want to designate one or two people with vacations and patient care that was occurring. So everyone is responsible for opening up that report, and it's first come, first serve. Whoever's available creates a phone encounter, and within 24 hours makes 2 attempts to contact the patient. If they were not reached, then the behavioral health clinician would look to the demographics section of our EMR and contact the patient's emergency contact to see if there was some additional means of contacting the patient. If that resulted in, again, the inability to reach the patient, then the behavioral health clinician would be consulting with the PCP via an urgent in-basket message, or they could pick up the phone and call the provider as well. From there, the PCP and the BHC would have some clinical decision-making about whether or not to call non-emergency police or complete a health and welfare check. So again, this is in response to looking at, we have those 4 questions, the 4 additional questions that helped us identify, was the patient just feeling that they'd be better off dead? Did they have active suicide ideation? So that clinical decision-making is also guided by the patient's responses to those 4 questions and a thorough chart review of their history. If there was action to occur, no matter what occurs at the end of those 2 contacts, the BHC completes the documentation and routes it to the primary care provider so that they're informed about the process and the follow-up. In the event that the patient was contacted at any point in those first 2 calls, the BHC, their role is to briefly screen, intervene, and refer the patient to the right level of care. So it's a triage service, not meant to be an ongoing support service to the patient, but almost a behavioral concierge, just understanding how the patient is doing, if there are imminent safety issues, looking at risk and protective factors, and developing safety plans as needed. The BHC has some standard documentation tools that they use for this outreach, and it includes a lot of risk and protective factor statements and documentation to be assessing. It also has some decision support tools for our behavioral providers regarding to expectations around safety plans and communication with the primary care provider regarding follow-up. Upon completion of that interaction with the patient, after determining what their need was and making referrals as needed, the BHC routes that completed documentation to the primary care provider. So as I mentioned before, we have 9 behavioral health clinicians at this time across 7 primary care sites, soon to be 8 at our Maple Grove Clinic. They are licensed mental health professionals, typically either a PhD psychologist, licensed independent clinical social worker, a licensed marriage and family therapist, or a master's level psychologist. To do this work and to establish safety and efficiency in doing this work, we developed standard processes for BHCs to monitor that report and provide outreach and intervention and communication to the primary care provider as needed. We, as I mentioned, also developed those standard EPIC templates and had some very thorough orientation for the BHCs. It was also really helpful to have that BHC champion in this work. We wanted our primary care teams to know that we were doing this work, that it's almost like Big Brother watching over the patient population for them, that it's not just them left alone to support these patients who may have some risk. So we created standard system communication to go out to all primary care staff, and that's something that we are continuing to distribute to teams to make aware that this is work that's occurring. And it's meant to be collaborative, and the response we've gotten from our primary care team members has been very positive. Oftentimes very appreciative, because when they encounter a patient who has potential risk, it's not always well known all the resources and team members available to support them in working to help these patients. So in conclusion, the main thing that we really want to emphasize through this work, and that our VP of Quality and Innovation brought to senior leadership as we pursued this work, was that we want to think safety first. We know that we are always striving for efficiency in completing our Minnesota Community Measurement goals and quality improvement areas, but that can't come at the expense of safety. And so we really wanted to let patients know as they're completing this assessment what they can expect in terms of follow-up, and have some stopgaps with our behavioral health clinicians to catch the patients that might otherwise fall through the cracks, who had a positive response and didn't show up for that appointment where they could get some support. I can say that the BHCs have received that very well, and surprisingly, not a lot of patients fall onto that report. Most folks do make it in for that appointment. With this work out, Linda and I both strongly would encourage that you identify a leader in the organization to really champion the work. System work like this really requires a higher level of support, and there's a lot of decisions that occur at higher levels, and these are things that a champion can address for you. And be relentless. This work takes time. It changes frequently, and you need to have lots of different opinions, and it's great to have lots of ongoing communication and collaboration around this type of work. Involving folks like risk management, your internal and community resources, and frontline staff to get their feedback on the work that's being developed is key, and it all takes work and time. And we'll turn it over to Joe to facilitate question and answer now.
Thanks, Chris. Thanks, Linda. Terrific job, and what a wonderful process you've got there. Rebecca, will you please open the phone lines for Q&A? We're not seeing anything yet in the chat, so feel free to either do that, or Rebecca will guide you as to how to do a phone question. Go ahead.
We will now begin the question and answer session. If you have a question, please press star, then 1 on your touch-tone phone. If you wish to be removed from the queue, please press the pound sign or the hash key. If you are using a speakerphone, you may need to pick up the handset first before pressing the numbers. Once again, if you have a question, please press star, then 1 on your phone. And our first question comes from Barb Anderson. Barb, your line is open.
Hi, can you hear me okay?
Yeah.
Yep.
Okay. Couple questions. I'm not familiar with my chart, but when you have the patient fill out the PHQ-2 or PHQ-9, depending upon the result, is that filled out prior to the date that they come in for their appointment?
Yes. So if they're completed it via my chart, that's an electronic means of completing the survey, and it's sent out 7 days in advance. I think, is that right, Linda? 7 days in advance of the appointment?
That's correct. Okay, and how do you, if a patient is elevated and they come in for their appointment that day and they are diagnosed with depression, how do you, with Minnesota Community Measurement, at least we've been told that PHQ-9 has to be done on that day in order to quote, count for the measure. How do you get by with that?
Well, Minnesota Community Measurement, when it comes to phone, the PHQ-9 can be completed via phone, in person, or electronically. And so it just has to occur within the time frames that they require. So,
but for the initial contact I'm talking about.
Oh, okay. And it just
because that has to be done during a face-to-face visit.
So I think we would have to look into that more ourselves.
Okay. Because we were told we couldn't send it out beforehand, and if it was greater than 9, then it, not that we want to have a million patients in the measure, but they told us that it had to occur on the date that the visit was. Follow-ups obviously don't, but just asking. And then, do you have any problems?
One thought I would add about that is just that although they might be completing the PHQ-9 before the visit, the diagnosis for a new patient wouldn't occur until they've actually been in clinic. And for all the patients that are receiving the MyChart PHQ-9 are established patients. So typically a patient is not on MyChart unless they've already been established, so it would be a follow-up annual exam.
Okay, yeah, we were still told we couldn't do it prior to the appointment. So are there issues with your PCPs addressing their positive suicidal ideation in basket messages? Just curious.
We haven't heard any concerns about that.
I guess in a timely fashion is what I'm trying to ask.
Yeah, we have not heard any concerns about that.
Okay, great. Thank you.
We've got a bit in the chat window now, so let's take a look at that. One of the questions is, what's the process for initiating a transport hold from the clinic if necessary? Chris, Linda, can you address that one?
Yeah, so a transportation hold can be completed by a health officer, and that would be a provider or a licensed mental health professional such as an LICSW. The transportation hold is an involuntary process for patients that need to be further evaluated in the emergency room, and that form has to be completed. So there's a standard form that you would complete. It has some carbon copies, one for the patient, one for the emergency medical transportation team, and one for the clinic. So working with EMT is key in that, and also at times you have to have the police there, because even though EMT is showing up for an involuntary patient, the patient may not, and because they're showing up for an involuntary patient to be assessed, the patient may not always be agreeable. So it's nice to have their support there just as needed.
We have another question in chat. First of all, thanks for the presentation. When the patients fill out the PHQ-9 ahead of time or a non-provider reviews the screenings with patients, are you able to bill for these services? Does the provider ultimately sign off that the screening occurred? The note is our partner in Wisconsin, working with a lot of organizations who have had a desire to integrate behavioral health services into primary care, but reimbursement makes it difficult to hire someone in an integrated role. So again, the main question is about billing.
Linda, are you aware of how the charges work for that?
No, I'm not. Sorry.
I don't believe we are charging for MyChart PHQ-9. The integrated behavioral health role, I can speak a little bit about the charges for those providers. Those BHCs are billable providers. They're licensed credentialed mental health professionals, and they are able to bill for face-to-face contact with patients. So if a warm handoff occurs where the patient came into clinic after having completed a PHQ-9 and the provider had concerns about their safety, they could go grab the BHC who's available for that same day warm handoff. And the patient and provider, or the BHC, would further discuss their responses. There would be a brief intervention and referral as needed. the warm handoff that we conduct is generally a non-billable service, unless there's been consent given by the patient for additional charges to occur. One of the great things we've learned through our private pay partners, such as Blue Cross and the state Medicaid program, is that there is no same-day copay for services received. Two services haven't been received on the same day within the same clinic and PI by different provider types.
Thanks, Chris. Next question is, how do you track patients that need follow-up on PHQ-9s?
And I wonder if this is related to patients that I may need a little more clarity on this question. If it relates to patients that have not completed the PHQ-9 at the time we need to capture it for Minnesota Community Measurement for follow-up, or is it more clinically related?
This question is from Samantha. Samantha, can you add clarity there? In the meantime, while we're waiting for that, Rebecca, are there any calls queued up?
Yes, we have a few questions. Kirk Yockler, your line is open.
Yeah, wonderful. Thank you. So I think one of my questions is actually one that I see on the chat, which is what percentage of your PHQ-9s are being completed via MyChart?
Oh, I don't have that information right at hand, but I could gather that at another point and send it to Joe. Joe, would that work?
Sure. Any rough estimate, Linda, ballpark?
We do get a lot of annual exams that are filled out. I couldn't give you a percentage, but there are quite a few. I mean, some clinics are better than others. It depends on the locations of the clinics and their clientele. I would say 20 to 30% would be a guess.
Sure.
Of the annual visits that are scheduled.
Sure. We mentioned MyChart several times. For those who aren't familiar with it, MyChart is the extension of the Epic Care system as a patient portal with various types of functionality, including obviously the ability to do what Fairview is doing here.
So two other quick questions. The disclaimer, that's brilliant, by the way. That's exactly what we need to do in our own services here to pursue a similar model. Is that proprietary? And why the Pfizer permission?
We had to receive Pfizer permission because the PHQ-9 is copyrighted by them. So in order to display something on that same page, we needed their permission. And what their response was that it's open source, so they had no problem with that, with adding that disclaimer to the top.
So is that a disclaimer that other organizations could copy?
Chris, I'll let you answer that.
Yeah,
It was defined by our leadership.
I would take that back to our leadership. Yeah, I would be glad to do that and give a response to Joe.
Okay, last question, and then I'll turn it over to others. How does the data, if they're completing it in MyChart, and maybe you covered this in the presentation and I missed it, but how does it get translated into Epic? Does it manually add it, or is MyChart able to automatically kind of load it into Epic for you?
MyChart automatically loads it into the one doc flow sheet that we landed on. We used to have several different flow sheets based on different builds over the past years. So we consolidated all those different doc flow sheets into one flow sheet. So now when they answer it either in the clinic on paper and then it's entered manually into Epic, or if it's done electronically through MyChart, it all flows into one flow sheet. So if it's done electronically, it electronically loads into the flow sheet and updates health maintenance and best practice alerts.
Wonderful. Thank you.
Mm-hmm. There's one piece of data that I did pull out yesterday, and that was the number of times the BPA fired for these MyChart questionnaires. And since last October, there was approximately 400 times that BPA fired for suicidal ideation and sent alerts to PCPs.
Thanks, Linda. We have a follow-up on that previous question from Samantha. The question was related to Minnesota Community Measurement. Once the patient is positive, how do you track to make sure they come back or complete a PHQ-9 in that time frame window?
We have some reports that are built that do internal index data, and we're actually working to improve that right now. We are learning that DHS, when you upload your PHQ-9 data to them, that they'll actually spit back a result to say, here's the index dates of the information you uploaded. And so instead of us trying to do the guesswork around what people's index dates actually are, we've learned that DHS will actually be, Minnesota Community Measurement at DHS will be providing that information for us to then integrate into our health record. So we have a monthly report that's run by the care team at each clinic, and the care team members provide outreach to the patient to complete that follow-up PHQ-9.
Great. Thanks, Chris.
It lets you know each month who's due in the near future for a PHQ-9 follow-up.
There's a chat question. Have you considered having PHQ sent to the patient for every visit versus annually? We are currently handing paper PHQs to patients at check-in of every appointment, but are wanting to move to MyChart flow.
Yeah, I think this was generation one of our initiative, and we certainly, I think, see other areas of opportunity. And we were trying to, on the front end, just balance our capacity. For example, the BHC is not knowing how many patients were going to show up on that daily report and whether or not they would have the capacity to support the patients that might otherwise fall through the cracks.
Great, thanks. Any other phone questions queued?
Yes, we have a question from Maria Gills. Maria, your line is open.
Hi, we're actually on the Fairview system. I was wondering, would I have to report to Epic Super User for more training on how to use the MyChart PHQ-9? Or can I contact you guys?
I would say start with your super user, and then maybe go to the quality team. Are you part of the quality initiatives?
No, we're working on our panels at our clinic where I'm actually UMP. Clinic.
Oh,
UMP,
yes, I know.
Yeah, UMP does have their own process.
They have their own process for the MyChart PHQ-9?
That's something that they're doing. They're using the MyChart PHQ-9 with the disclaimer. That disclaimer went across the board for UMP and Fairview.
Okay.
But the follow-up work done by the BHCs is a Fairview service.
Okay.
There are conversations right now as we're hiring some additional BHCs to work in the new clinics and surgery center on our East Bank campus to begin that service as well.
Okay, and that would be across the whole organization, correct? Well, we're in the East Metro, and I know we use a lot over here just because our patient population doesn't get over there.
Maria, excuse me, this is Joe. Since this is kind of an internal issue, perhaps we could take this offline as we move back to broader questions. Is that okay?
Sure. Yeah.
Okay. All right. Thanks so much. Another phone question?
Okay, our last question is from Kristen. Your line is open.
Hi there. I'm just wondering if you can tell us what you do with patients that do not have MyChart. What is your workflow or process?
That would be our standard rooming. So when the patient comes in, they would complete the PHQ-9 via doc flow sheet with the rooming staff.
Okay, so not necessarily a nurse or a behavioral health specialist. It could be a medical assistant as well?
Yep.
Okay.
And then they would have additional support available if there was a concern in that visit.
Okay, well, thank you.
There's a chat question. Is there a mechanism for other people at the clinic to be notified of harm to self or others if the assigned PCP will not be checking the in-basket, for example, vacations and such?
The clinics do have processes for monitoring in-baskets for people who are out. So somebody else would attach to their in-basket and work their messages. It's not just a best practice alert, but results and other things. So that would be part of the standard coverage for people who are out of office.
All right, great. A couple more in the chat window. What about other languages? Are you able to do PHQ-9 in other than English?
Not at this time, not via my chart.
Is that available on site if the patient were to do that at the point of service?
Yeah, we do have some PHQ-9s that have been translated for other languages. And those are in paper form. That they wouldn't show up in our electronic medical record in different languages.
Sure. Okay. If a PHQ-9 indicates that a patient is highly suicidal or for some reason the patient hasn't gotten back in a few days, or perhaps they fill it out on a Friday night and the client commits suicide, is there a liability for the clinic since technically the clinic now knows that the patient is suicidal? How's that for a heavy question as we wrap up?
Yeah, we certainly do our best with the disclaimer to direct patients to the right resources at the right time, and we do inform them that in that disclaimer we will not be monitoring those responses until they show up for their appointment. The stopgap service that we're providing is not anything that we're advertising on the front end for patients. That if they have a positive response and don't show up for the appointment, we're going to have outreach to them. So there's no discussion with the patient or no information provided to the patient to have any expectation that there'll be follow-up in those instances, but we do. And so these are as you're talking about liability, these are the important parts of having system leadership as a part of your work group. Going back again to having a champion for this work who can talk on a higher level with risk management, as this all had to obviously go through those channels.
Great. Thanks, Chris. Another question. Does the provider ultimately sign off that the screening occurred? First, do some PHQ2, PHQ9s without an actual office visit happen? And if so, for those without an office visit encountered, does the provider sign off?
The only other reasons that I know of that an electronic one would be sent would be for a refill, a medication refill, or if it's being sent to the patient because they're due for one, and that's, again, by an RN. I don't believe that providers sign off on those, but the person sending those would confer with the PCP if there were concerns. Chris, do you have anything to add to that?
No.
Okay. Have you utilized the website Impact that is through Pfizer?
Yeah, the Impact website is a great resource, as it's the origin of the Diamond Project, and it was a great resource for us as we looked at best practice follow-up and support for this population of patients.
Great, thank you. Is there a diagnosis code for patients that have a positive PHQ-9 for the first time you know they have a new diagnosis? And how do you know if this is the first elevated PHQ-9 for indexing to Minnesota community measurements.
Yeah, there's no DSM or ICD diagnoses for depression indicated as the first step. I mean, that we would use for first episode. Our providers, generally, primary care providers, use the diagnoses that they're trained in, which would be mild, moderate, severe depression in these situations, given that the patient has met criteria. The recurrence is something that providers can look at, and that would be a recurrent form of depression, but that's not how we're tracking Minnesota Community Measurement Index. The index, as I was stating, is something that we're still wrapping our heads around and getting a better handle on, and we are working with Minnesota Community Measurement to optimize that ourselves.
Great. Thanks, Chris. Are there any other phone questions queued?
We have no audio questions.
All right. Thanks, Rebecca. We'll do a quick check here to make sure we didn't miss anything in chat. Just a moment, please. I think we're good. Thank you, Chris. Thank you, Linda, for, first of all, a wonderful presentation and also for very thoughtful responses to actively engaged participants. Thanks also to the participants for being so actively engaged. At this point, we are ready to wrap up. Rebecca, I'll turn that back over to you.
Thank you, ladies and gentlemen. This concludes today's conference. Thank you for participating. You may now disconnect.